Hey there, welcome back, and this is Dr. Pawan, your surgery educator on Unacademy platform, and today we are here to talk to you about the weekly quiz in surgery part 5. So let us begin and let's talk about it without wasting any further time. The first question which I have for you is, there's a 35-year-old woman who is presenting to you with an abdominal pain and jaundice. Okay, subsequently an ERCP was done, which basically showed a congenital cystic anomaly of a biliary system illustrated in the film which is given to you. Now, what is the most appropriate management of this particular patient? So here, let's summarize it. So what is this? There is a female who is coming to you with abdominal pain and jaundice. The female is around 35 years and you did an ERCP, and on ERCP you found the image which has been shown to you. We will dissect this image, don't worry, but yeah, this is the image which has been shown to you, and the question is trying to ask you what is the most appropriate management of this particular patient. Now let us have a look at this particular image. So first of all, this is an ERCP. So this is an ERCP, and what you are getting in this ERCP is, so I hope you are able to appreciate, this is a common bile duct. So this common bile duct, does it look dilated to you? Yes, it is. It is in fact dilated, and this is also a gallbladder. So here the extrahepatic biliary tree, that is the gallbladder and the bile duct, that has been dilated in this particular patient. Now what is this patient suffering from? Well, yes, the patient is suffering from choledochal cyst, that is a congenital cystic dilation of the biliary tree. Now let us evaluate why does choledochal cyst occurs. So the theory behind the formation of a choledochal cyst is that it forms because of an abnormal pancreatico-biliary junction. Now normally what happens, our bile duct comes and our pancreatic duct comes, they join together and then they open directly into the duodenum, the second part of the duodenum. But if at all, let's say there is a long common channel, what will happen? The pancreatic secretions, okay, so if at all there is a long common channel, the pancreatic secretions can actually enter into the biliary tract, and it can lead to the weakness of the wall of the biliary tree, which ultimately leads to the dilation of the biliary tree. And this is the pathogenesis behind the choledochal cyst. I hope you are able to understand it. Okay, so if at all there is a long common channel which happens in the abnormal pancreatico-biliary junction, what is going to happen? The pancreatic secretions are going to enter into the biliary tree, leading to the weakness of the wall of the biliary tract, leading to the dilation, which we call it as a choledochal cyst. Now there are various types of choledochal cysts, so we divide it into 5 types based on a classification which is called as a Todani classification. Now earlier there was an Alenzo classification. This Todani classification is a modified version of that Alenzo classification, but yeah, this is what we follow nowadays. So let us walk you through it. So it divides the choledochal cyst into 5 types. So type 1, there is a fusiform dilation. So what do you understand by a fusiform dilation? If I just ask you, what do you understand by this fusiform dilation? Now please understand, fusiform means that the entire circumference of that particular lumen is getting dilated. Okay, so please remember this, fusiform. Anywhere in the body where if you have some fusiform, let's say a fusiform aneurysm, it means that the entire circumference is getting dilated. That is what is referred to as a fusiform. So type 1, this includes fusiform or a cystic dilation of a common bile duct. So here there is a dilation of a common bile duct, but there is a fusiform or a cystic dilation. Then what do you have? Type 2, you have a bile duct diverticulum. So many students get confused between what is type 1 and type 2. What exactly is the difference? So in the type 1, what do you have? You have a fusiform dilation, that is the entire circumference is getting dilated. In the type 2, what do you have? You have a diverticulum. So let's say if at all there is a common bile duct, a part of the common bile duct is getting dilated. So there is a diverticulum. This is also referred to as a saccular dilation. So saccular dilation or a diverticulum arising from a common bile duct, this is type 2. Okay, so I hope you understood it. Type 1, fusiform dilation. Type 2 is, let's say, a diverticulum or a saccular dilation, whatever you want to call it. The type 3 is basically choledococele. Now what is this choledococele? The part of the common bile duct, it comes and attaches to the intestine, where it is kind of joining to the intestine. If at all at this particular position there is a dilation, this is what is referred to as a choledococele. This is type 3. Then type 4 is divided into type 4A and type 4B. Type 4A is basically if at all there is a dilation of an extrahepatic as well as intrahepatic bile ducts. Type 4B is only there is dilation of an extrahepatic bile duct. And type 5 is a Caroli's disease. Caroli's disease means there are multiple intrahepatic dilations. So I hope you get this. These are the 5 types of a Todani classification. I'll just walk you through them again on the basis of this image, so you can have a look at it. Simple. Type 1 is a fusiform dilation. Type 2 is basically a saccular dilation or a diverticulum. Type 3 is basically choledococele. I hope you are able to appreciate this. Okay, at the point where it is coming and attaching to the intestine, at that particular position there is a dilation. Type 4 is divided into type 4A and type 4B. In the type 4A there is an extra and intrahepatic both, so yeah, both are dilated. In the type 4B only the extrahepatic biliary tract is dilated, and the Caroli's disease type 5, that is multiple intrahepatic dilations. I hope you get this. This is a classification. Now let's come back to the image which we had. So we had an image of an ERCP. What kind of a choledochal cyst are you able to appreciate in here? So here what you're able to see is extrahepatic, okay, extrahepatic dilation. This is most probably type 4B. Okay, now okay, that's there. So patient is coming to you with an abdominal pain and jaundice, that's fine. So will you go for, okay, so now let us have a look at the options. How will you manage this particular patient? The first option says that will you go for a cholecystectomy with the resection of the extrahepatic biliary radicals with the Roux-en-Y hepaticojejunostomy? Well, we will look, is this the answer or not? The second is basically internal drainage via the choledochoduodenostomy. Well, please understand, in the choledochal cyst, we don't go for a drainage procedure. So the type B, like option B and C, they are suggesting that let's go for an internal drainage, either by the choledochoduodenostomy or a choledochojejunostomy. We don't prefer to go for an internal drainage. Why? I will tell you why. But yeah, please understand, we don't prefer to go just for an internal drainage. For example, like we do in the kind of a pseudocyst of pancreas, we go for an internal drainage. But here in the choledochal cyst, we do not go for an internal drainage. Now, percutaneous transhepatic biliary drainage, again we don't drain. And the liver transplantation, well, this is specific for the type 5 disease. For the Caroli's disease, we prefer to go for liver transplantation. Now please understand, the answer is A. Why do you want to kind of resect this particular cyst? Why do you want to completely resect this particular cyst? The main reason why we want to resect this particular cyst is because this is a pre-malignant condition. A patient who is coming to with a choledochal cyst, it may transform into a malignancy. It is a pre-malignant condition, and that is why you have to go for an entire resection. We don't prefer to go for a drainage procedure because our main problem is not the drainage of the bile. Our main problem is maybe this particular patient might land up into cholangiocarcinoma and might come to us. And that is why we have to go for a surgical resection of the cyst. And after that, obviously you have to drain kind of the bile. So you will have to go for a hepaticojejunostomy. I hope you understand this. The answer is option A. Now, let us move on to the next question. The next question is, there is a full-term newborn kind of child who is experiencing a respiratory distress immediately after the birth. The prenatal sonogram was read normal. An emergency radiography was done and it has been shown to you over here. A patient is intubated and placed on 100% O2. Arterial blood gases have been shown. The pH is around 7.24, PCO2 is 60 and PCO2 is 52. Now the baby has sternal retractions and the scaphoid abdomen. Which of the following should be performed in the management of this particular patient? So what do you think is the answer in this particular question? First, let us dissect this particular scenario. So here you have a kind of a child who came to you with a respiratory distress. Prenatal ultrasound was normal, but postnatal radiograph has been shown. And what you're able to see in this, so okay, normally what you have a normal looking lung field over here, but here what you're able to see is that the parts of the intestine have kind of gone up, and that is why all these kind of black shadows are seen in the like on the thoracic cavity. At the same time, if you are able to appreciate, the cardiac shadow has shifted towards the left side. I mean, it has shifted towards the left side. Okay, so it has shifted towards the right side, and this is because the part of the intestine is going into the thorax and pushing the mediastinum towards the opposite side, and this is the reason why the patient is having respiratory distress. So the diagnosis is pretty simple. The diagnosis is congenital diaphragmatic hernia. So this is a patient who is suffering from a congenital diaphragmatic hernia. Okay, right. So this is a patient who is suffering from a congenital diaphragmatic hernia. Now, how do you manage this particular patient? Okay, so now let's look at the other part of the question. Okay, so can we diagnose it prenatally? In the question, it has been shown that the prenatal ultrasound was normal. Can you diagnose it prenatally? Well, yes, you can. But yes, it may be missed, and in this particular patient, it was missed. But yes, you can diagnose it prenatally. And if at all you diagnose it prenatally, like we are prepared when the child is born, we are prepared, we know what we are dealing with. But in this particular scenario, the prenatal sonogram was normal, which can happen, which can miss, but ideally it should not be kind of missed because it can be diagnosed prenatally. Now, let's move on to the other thing. So in this particular patient, because of this respiratory distress and all, the patient is in the respiratory distress. Why? Because the PO2 is low and the PCO2 has increased and the patient is in a respiratory acidosis. So yes, patient is kind of suffering from acidosis. If you examine this particular patient, what you're able to see that there is a sternal retraction, and then there is a scaphoid abdomen. Now the scaphoid abdomen is also a buzzword which they kind of use. Now what do you understand by scaphoid abdomen? Normally our abdomen is kind of a bit protuberant or something like that, but in this particular patient what is going to happen, this is a normal abdomen which we have, but in this particular patient, let's say this is the chest and the abdomen is like this. So this particular position is called as a scaphoid abdomen. I don't have an image of that, but yeah, this is what you look as a scaphoid abdomen. So in this particular patient, all these particular collective findings are pointing towards the diagnosis of congenital diaphragmatic hernia. Now the point of the matter is, how will you manage this particular patient? Will you go for an intravenous steroids? Well, no, you will not go for intravenous steroids. Will you place a bilateral thoracostomy? It won't help, because that will help if at all there is a kind of a pleural fluid accumulation. Then only the thoracocentesis or the thoracotomies will help. Chest tubes will help. But in this, we don't have any fluid accumulation or something like that. That is why the chest tubes won't help. Immediate thoracotomy with the lung resection, you don't need to do that. Immediate laparotomy with the repair of diaphragm, will you go for that? Do you think that? No, please understand. We will have to go for a laparotomy with the repair of the diaphragm, but it is not an emergency. The emergency is, first you want to stabilize this particular patient. You want to correct all these abnormalities, the acidosis. You have to bring the PO2 up. You want to bring the PCO2 down. And because of this, the immediate management, like the what is the preferred management, right? So what will you prefer to go for is mechanical ventilation with a low tidal volume. I hope you understand this. Okay, in this particular question, the next step which you are going to do is mechanical ventilation with low tidal volumes. I hope you understand this. Okay, once the patient is stabilized in, let's say, 1 or 2 days later, then you will prefer to go for a surgical repair of this particular diaphragmatic defect. Now let us move on to the next question. Which manure has been shown in this particular figure? So what is shown in this particular image is that they are basically putting an incision on a white line of told, which is basically along your kind of ascending colon, and then they are lifting this particular viscera and rotating it medially. Now, first of all, why are they doing this? Okay, why are they doing this? Because they want to gain access to the retroperitoneum. So let's say because they want to operate on, let's say, a left kidney, or let's say there is this inferior vena cava and they want to operate on inferior vena cava or something like that. So why are they doing this? Because they want to gain access to the retroperitoneum for any reason. Okay, for any reason. If they want to gain access to the retroperitoneum, they cannot go directly into the retroperitoneum. They have to mobilize the viscera. And for mobilizing the viscera, you have a couple of manures. One of them is a Cattlebrack manure, one of them is a Metox manure. So can you please tell me what manure has been shown in this particular image? If you're answering it as a Cattlebrack manure, you're absolutely correct. But yeah, let us have a look at it. So one is Cattlebrack, one is Metox, and many times students get confused. The other part of this is a Metox manure which is shown in this particular image. What they're doing in here, they're basically rotating the media, like the left medial rotation of the viscera. By doing this, what they are gaining access to? They are gaining access to the aorta. Okay, so by performing a left medial rotation, they gain access to the aorta. By performing the right medial rotation, they basically gain access to the IVC or the other retroperitoneal structures. I hope you understand this. Now, the whole point of discussion is how to remember Cattlebrack manure and the Metox manure. So for now, let us assume that what we are basically in a virtual classroom. You are sitting in your home, we are in a virtual classroom. So let's kind of remember the classroom for now. So yeah, so just a kind of a way for you to remember it. You can remember it as any ways. But yeah, let's remember it like a classroom. So what do you understand by classroom? Yeah. Virtual classroom. You can just remember this in order to remember the Cattlebrack manure. So Cattlebrack manure is the right medial rotation. So this is how you can remember it. Classroom stands for Cattlebrack, like class stands for Cattlebrack, room stands for right medial rotation. I hope you understand this, okay? And how to remember the kind of Metox manure? Well, it is exactly the opposite of it. Like the right side is a Cattlebrack, left side is a Metox. But if at all you want a kind of a simple mnemonic for that, so you can just kind of try to remember your ABCD, and when you kind of read that, your L comes and then after that M comes. So the Metox manure is a left medial rotation. So this is how you can remember it, okay? So the Metox manure is a left medial rotation. This is how you can remember it. So just kind of some silly ways to remember it, but I hope it helps. So point of the matter is Cattlebrack manure is the right medial rotation and Metox manure is a left medial rotation. Okay, then What about this Prentice maneuver? What do you understand by this Prentice maneuver? Just an additional point, just remember, this is an intraoperative maneuver which you basically use when you are operating for undescended testes. So when you're performing a kind of orchidopexy, let's say Stephen Fowler technique, there is an intraoperative maneuver which you perform, which is called as a Prentice maneuver. Now forget about it. What exactly is this? This is basically performed in order to look whether the kind of arterial length is good enough for it to bring to the scrotum or not, but don't go into the details of it. Just remember, Prentice maneuver is something which you perform intraoperatively when you are operating for an orchidopexy. And lastly, the Pringles maneuver. So Pringles maneuver is a maneuver which you perform in the liver trauma in order to know what is the source of the bleed. Is the source of the bleed a hepatic artery or a portal vein, or is the source of the bleed a hepatic vein? Okay, so we will talk about Pringles maneuver in some other time, but yeah, this is what the Pringles maneuver is. Okay, now let's move on to the next question. The last question of the day is, a patient has come to you with a bleeding peptic ulcer. You did an upper GI endoscopy. On the upper GI endoscopy, you found an adherent clot. Okay, so you find an adherent clot. What is this particular stage of Forest's classification? Can you please tell me? So what is a Forest classification? Forest classification is an upper GI endoscopy. So whenever there is a bleeding peptic ulcer, you do an upper GI endoscopy, you have some or the other finding. Now they have tried to grade that particular finding and convert it into a classification system that is called as the Forest classification system. What is the use of that? Why did they kind of classify it? They classified it so that they can know what ulcer has a chance of recurrent bleeding, which ulcer is more likely to rebleed, and that is what is the Forest classification. Now it is divided into 1A, 1B, 2A, 2B, 2C. We will have a look at it, don't worry. But yeah, if at all you find an adherent clot, what is this particular stage? So this is basically 2B. Okay, so this is a 2B. Now let us have a look at the Forest classification. Okay, so this is the Forest classification. I'm sure you must have kind of seen this at least 10 times or maybe more than that, but I'll just try to kind of talk you through it and maybe you will remember it now. Now please understand. So whenever there is a bleeding which is happening from a bleeding peptic ulcer, what is the worst case scenario can happen? When you go and look at it, the ulcer is still bleeding and the bleeding is from an artery. So, like there is a pulsatile bleeding which is coming. So just kind of try to remember it as the phases of a bleeding ulcer. Okay, so in the 1A, what you will see, if at all you do an upper GI endoscopy, and if you are able to see the pulsatile bleeding, okay, if you are able to see a pulsatile bleeding, this indicates that this is like the worst case scenario. This is grade 1A. 1B is basically there is a non-pulsatile bleeding. So you can also refer it as a oozing of the blood. Okay, so this is the oozing of the blood or a non-pulsatile bleeding which can happen. This is 1B. Okay, so simple. 1A is basically pulsatile bleeding. 1B is basically oozing of the blood. That is a non-pulsatile bleeding. Okay, now let's talk about the grade 2. Now grade 2 is divided into grade 2A, grade 2B, grade 2C. Now what is a grade 2A? So here you don't have any bleeding or something, but you have a visible vessel. Okay, you have a visible vessel. So there is no covering over the vessel. There is no mucosa. There is nothing over the vessel. There is a visible vessel. It is not bleeding. But what do you have in the kind of a stomach? You have acid, and you have like the food going in and the continuous kind of peristalsis going on in the stomach. So any point of time, this visible vessel can undergo an injury and it may again start bleeding. So this is again a kind of a severe thing, and that is what is referred to as a grade 2A. Okay, so what do you get in the grade 2A? You have a visible vessel, non-bleeding visible vessel, that is a grade 2A. Then you have a grade 2B. What do you have in the grade 2B? So once the kind of a bleeding is over, what do you get? You get a clotting, right? You get clot at that particular point. So here there is an adherent clot. So you are not having a visible vessel, you are having an adherent clot over it. So it's a good thing, right? It is at least covered with a clot. So it is a bit safer as compared to that of just a visible vessel. That is why the risk of rebleeding, it is high. If at all you have a pulsatile bleeding, oozing of the blood, or you have a visible vessel, the risk of the rebleeding is high. But if at all you have an adherent clot, the risk of rebleeding is low as compared to these three conditions, because at least it is covered by that adherent clot. I hope you get this. Now coming to the grade 2C, here you don't have kind of any clot or something, but you have a kind of telltale sign that okay, so their bleeding had happened. So what is it? So our body had taken care of whatever the RBCs were there, it had kind of hemolyzed and kind of degraded it, but what is present over there is a pigmentation. So you have an ulcer with the black spots, which basically indicates that maybe the bleeding had happened and it has been taken care by the disintegration of the RBCs or something like that. So here you have a pigmentation which is present at that particular spot, 2C. Okay, 2C is pigmentation. And what about 3? You just have a clean non-bleeding ulcer bed. Okay, so just a clean non-bleeding ulcer bed as if nothing has happened. That is a grade 3. So I hope you get this. I've made it a bit melodramatic for just you to understand it. I hope you remember it. You can just pause this particular video right here, right now, and repeat it a couple of times. I'm sure you will be able to remember it over a period of time. So this is about the first classification. Last time I'll just repeat it. Grade 1A is pulsatile bleeding. Grade 2B, like 1B, is a non-pulsatile bleeding, which you can also refer to as a oozing of the blood. Then 2A, 2B, 2C. 2A is basically a non-bleeding but a visible vessel. 2B is basically adherent clot. The 2C is basically ulcer with a black spot, that is a pigmentation present, and grade 3 is basically clean non-bleeding ulcer blood. Out of this, grade 1A, 1B and 2A, it has a high risk of rebleeding. 2B, it has an intermediate risk of rebleeding, and the grade 2C and 3, they have kind of low rate of rebleeding. Okay, so that's all for this kind of short quiz, guys. The questions were a bit kind of on the easier side in this particular quiz, but I hope you kind of gain something out of it. Just leave your comments on the comment box, and yeah, just leave the topics if at all you want some particular topic on which you want a question to be framed. Thank you so much, guys. It was indeed a pleasure interacting with you. I hope you gained something out of it, and yeah, I'll just request you to just go and explore the Unacademy page. We are doing really good things out there. I hope you will explore it. I hope you will kind of now be willing to join a couple of things if at all you find them that they might be beneficial for you. If at all you wish to join anything, you can use my promo code, that is dr.pawan. You will get around 10% off on whatever you wish to join, whatever the subscription you wish to take. I'm sure that if you will join, you will get it benefited out of it. Thank you so much, guys, for watching this particular video. Stay safe, happy studying, and see you next week. Bye.